Well, welcome everyone. It is my pleasure to introduce our 26th annual Leon Schiff Lecturer, Dr. Guadalupe Garcia-Tsao. Dr. Garcia-Tsao is a professor of medicine at Yale University and chief of digestive diseases at the VA Connecticut Healthcare System. She is the current director of the Clinical and Translational Core of the Yale Liver Center, program director of the Hepatitis C Resource Center, and associate editor for the New England Journal of Medicine. She received her MD from La Universidad Nacional Autónoma de México and completed her residency and gastroenterology fellowship at the Instituto Nacional de la Nutrición. She then completed her clinical and research hepatology fellowship at Yale University VA Connecticut Healthcare, where she has been since 1990. Dr. Garcia-Tsao's research focuses on cirrhosis, portal hypertension, and related complications, and has been funded by the National Institutes of Health and the Veterans Administration. She has authored over 100 original research publications, in addition to several society guidelines and physician papers, on the topics of variceal hemorrhage, ascites, hepatorenal syndrome, spontaneous bacterial peritonitis, and transjugular intrahepatic portosystemic shunts. Dr. Garcia-Tsao served as the president of the American Association for the Study of Liver Diseases in 2012 and has received numerous awards, including the International Recognition Award by the European Association for the Study of the Liver and the Distinguished Clinician, Educator, and Mentor Award. Today, she will be giving a presentation titled Management of Cirrhosis and Complications. Without further ado, I pass over the stage to Dr. Garcia-Tsao.
Thank you so much for that kind introduction, for pronouncing everything very well. It is my honor, and I thank Jean for inviting me to give this lecture. Actually, I gave the Schiff State of the Art lectureship at the ASLD meeting some years ago, and I was very proud to do so. So I'm very, very proud to be giving this lectureship today. Let me share my screen now so I can show you my slides. So I will not go through all the complications. We'll talk mostly about varices, variceal hemorrhage, and ascites. So as you all know, cirrhosis is the end stage of any chronic liver disease. So you start by having no fibrosis all the way to cirrhosis, and this is due to increasing liver fibrosis. So stage 0, as you all know, there's no fibrosis. Stage 1, there's only portal fibrosis. Stage 2, there starts to be some fibrous tissue that's going out of the portal tract. Stage 3, there's bridging. So there's fibrous tissue that goes from portal space to portal space, or from portal tract to central veins. And then stage 4 is when you have cirrhosis. So you have regenerative nodules that are surrounded by fibrous tissue. And in any chronic liver disease, and now we're seeing NASH, our main question is, does this patient have cirrhosis? Why? Because that is the deal breaker. If in hepatitis C, there's a survival was dependent on the presence or absence of cirrhosis. In NASH, it's a little bit more granular. So you have the best survival with stage 1, the worst with cirrhosis, but you have the intermediate stage that also carry a survival impact. But anyhow, but in any patient with chronic liver disease, the first question is, does this patient have cirrhosis? And we used to say cirrhosis is just cirrhosis, and everybody was in the same box. But we now know, based on many studies, that there's at least 2 main stages. So when you see a patient with cirrhosis, you have to figure out, is this patient compensated or decompensated? Decompensation is defined by the presence of overt complications, variceal hemorrhage, ascites, and encephalopathy. And they're entirely different because the compensated cirrhotic patient, while he or she remains compensated, has a median survival that exceeds 12 years, whereas any time any of these events occur, the median survival goes down to 2 years. So they're entirely different prognostic entities. And the main driver of decompensation is portal hypertension, and something that we call clinically significant portal hypertension, which is defined as an hepatic venous pressure gradient more or equal to 10. Normal is 3 to 5. So this is the way it goes. You have architectural distortion. I just showed you regenerative nodules surrounded by fibrous tissue. This increases the resistance to portal flow inside the liver. So right away, there is mild portal hypertension. So the hepatic venous pressure gradient is more than 5, which is abnormal, but it's still not more than 10. But this increase in pressure is already sensed by splanchnic arterioles that produce more nitric oxide. Therefore, there's splanchnic vasodilation. So this is more blood into the portal system. And this increase in flow then increases pressure, and now the patient has clinically significant portal hypertension. And it's only then that collaterals will open. And these collaterals, the most important ones, are varices that form when these veins in the esophagus protrude through the mucosa. Now, at the same time, this vasodilation is not only splanchnic, but it's also systemic. And this is felt by baroreceptors as hypovolemia. And this leads to activation of neurohumoral system, renin, angiotensin, aldosterone, sympathetic nervous system. These are all vasoconstrictive systems, and sodium retaining systems that lead to hypervolemia. And this leads to an increased cardiac output, a hyperdynamic circulation that increases flow even further, and therefore makes pressure increase more. Additionally, these neurohumoral systems, like I said, are vasoconstrictive and cause constriction inside intrahepatic vessels, increasing resistance even further. So you see, this is like a vicious cycle. When there's increase in the pressure in the sinusoids and water retention, you'll have ascites formation. If flow is increasing to the varices, they grow and they will eventually rupture and leading to variceal hemorrhage. And when ammonia is being shunted away from the liver because of the presence of portal systemic shunting, you will get hepatic encephalopathy. So the three main decompensating events result directly from CSPH. Now, as far as we're concerned, once you see a patient with compensated cirrhosis, the main goal is to prevent decompensation. And now we know who to choose. I mean, so we can now even further individualize the care, because there are the patients with CSPH that are going to be more likely to decompensate. And we're not talking just variceal hemorrhage, we're talking ascites, which is the most common decompensating event, and encephalopathy. In patients with mild portal hypertension are essentially never going to decompensate while they remain with mild portal hypertension. So our goal there is to eliminate the etiology. But since pressure is driving this decompensation, what we have to do is lower portal pressure. And how do we do this? For many years, we're talking more than 35 years, we have been using non-selective beta blockers, and they decrease portal pressure by decreasing this increased flow. So that's their site of action. The typical classical non-selective beta blockers act by beta-1 adrenergic blockade, decreases cardiac output, but the main effect is actually splanchnic vasoconstriction due to beta-2 adrenergic blockades. That's why we need non-selective beta blockers. Now, carvedilol is a particular type of non-selective beta blocker that, in addition to having these effects, also have alpha-1 adrenergic blockade effects, which we think there's a vasodilating effect, act in the intrahepatic circulation. And that is why in all of our studies, carvedilol has a much stronger portal pressure reducing effect than the classical non-selective beta blockers. So the question is, can non-selective beta blockers actually prevent decompensation? And the answer is in this study. This is the Predesi trial that was published in Lancet a couple of years ago, actually a year ago, but this was a randomized controlled trial, multi-centered, placebo-controlled, in which patients with compensated cirrhosis and CSPH, so they actually measured the HVPG, but they had no or small varices. They excluded patients with moderate to large varices because it would have been unethical to randomize them to a placebo. So the endpoint was not variceal hemorrhage only, but it was any decompensating event or a liver-related death. And you can see the main results are in this graph. Beta blockers were significantly associated with a lower rate of decompensation, of any decompensating event. When you look specifically at the three decompensating events, ascites was the only one that was significantly different between study groups, 9% in the beta blocker group versus 20% in the placebo group. And that is because ascites, again, is the most frequent decompensating event. Now, 1/3 of the patients got carvedilol and 2/3 of the patients got propranolol. And carvedilol at doses that range between 6.25 to 25 every day seem to be more effective than propranolol, as we had shown previously looking at HVPG trials. So they all use the maximum dose titrated to heart rate and blood pressure. So this is evidence that we can actually prevent decompensation by using non-selective beta blockers. Now the issue is, are we going to measure the HVPG in every patient to determine whether they have CSPH? The answer is no. HVPG is an invasive procedure. You go through the jugular vein, goes through the heart into the hepatic vein, and one wedges and then frees the catheter, and that's the HVPG. But there are now non-invasive ways to determine if someone has CSPH. So in a patient with compensated cirrhosis, if the patient has varices, any size varices on EGD, by definition, they have CSPH. If they have portal systemic collaterals on MR or CAT scan, they also have CSPH. If they have a liver stiffness, I don't have time to show you the data about this, but this is in these anticipate studies, show that a liver stiffness measurement of more than 25 kilopascal in most etiologies of cirrhosis, except for obese NASH, this is predictive of CSPH. And if the liver stiffness is between 20 and 25 and the platelet count is less than 150, this is also has a very good positive predictive value for CSPH. So the way this is a paradigm shift. Unfortunately, we canceled the Vavino conference because of the pandemic, but this is what is going to be coming up. So now, once we diagnose compensated cirrhosis, one should do a liver stiffness measurement and a platelet count. If there's evidence of clinically significant portal hypertension, instead of going back and doing an endoscopy, we know that these patients, we can prevent decompensation by giving them beta blockers. So we would recommend starting carvedilol or propranolol to prevent decompensation. I would favor carvedilol because it has a greater effect. If patients do not meet these criteria, one can monitor this on a yearly basis, totally non-invasive. On the other hand, if one finds a patient that is referred to you because they have varices on endoscopy or have abdominal collapse on imaging, so these patients by definition have clinically significant portal hypertension, one has to do a lab test to determine whether this is a pre-hepatic or pre-sinusoidal portal hypertension or whether this is cirrhotic portal hypertension. So if it is, if after all your investigation, you conclude that the patient has cirrhosis, you go directly to starting carvedilol or propranolol because you know that they have clinically significant portal hypertension. If, on the other hand, the patient does not have cirrhosis but has varices, you know that it's a pre-hepatic or pre-sinusoidal portal hypertension, then it becomes important to figure out if they have varices. So one goes to the old paradigm, which is to start propranolol or carvedilol if varices are moderate or large size. And the objective here is to prevent variceal hemorrhage, which is actually the main complication that they will have. Preventing decompensation is a much loftier goal in a patient with cirrhosis. Now, what else can we use to decrease portal pressure even further so we can even have a greater effect on preventing decompensation? We can act on resistance. Now, most of it, 70% of it is fibrous tissue, is nodules, nothing that you can really fix. 30%, however, is functional. There's this vasoconstriction, and this is due to a decrease in nitric oxide in the intrahepatic vessels. Statins include increase the bioavailability of nitric oxide in the intrahepatic circulation. Vasodilates, decreases resistance. And this is a proof of concept study. It's a beautiful study that looked at placebo versus simvastatin, up to 40 milligrams a day for 4 weeks. You see no decrease in HVPG with placebo, a modest but significant decrease in HVPG with simvastatin without changes in blood flow, which indicates that this decrease is due to a decrease in resistance. If you think about it, with something that's dilating the intrahepatic circulation, you're going to get more flow to the liver. ICG clearance is a measure of liver perfusion and therefore of liver function, and this improved with simvastatin as one would expect. Now, it wasn't that we hadn't been thinking about using vasodilators, but we had been using, nitrates, sildenafil, etc. And they all were accompanied by a decrease in mean arterial pressure because they would vasodilate the systemic circulation. Statins only dilate the intrahepatic circulation and have no effect on blood pressure. So we're very comforted by this. And there's data from retrospective cohorts, including one from the VA in HCV compensated cirrhosis. There was a propensity score match study. And you can, at the outset, all these patients were selected. They were matched by their cardiovascular risk, their hyperlipidemia profile, and their severity of cirrhosis. And statin users were 45% less likely to decompensate and 44% less likely to die than compared to non-users. When we looked specifically at decompensating events, look at this. There was a significant reduction in ascites. This is like 41%, and a very significant decrease in the rate of variceal hemorrhage. There was another VA study using a database, the VA vocal database that comprises all etiologies of cirrhosis. And in this study, statin use was associated with decreased mortality in child, not only A, which was our study, but also child B patients. And we now have an ongoing RCT, a VA multi-center study, which is called the VA Sacred Study. And the NIH just had an RFA out for a trial on statin. So in the not very near future, but in the future, we will have the results of statins in preventing decompensation. Now, let's go on to the decompensated stage, and let's talk about variceal hemorrhage. It is not the most common, but it's an episodic and a deadly complication of ascites. And so the standard of care, and I'm going to go over this, I'm just going to go through the pathophysiological highlights. We recommend cautiously transfusion. And this is based on this study in the New England Journal of Medicine already some years ago that looked at a restrictive transfusion strategy, meaning you only start transfusing when the hemoglobin has hit 7 and you keep it around 8, versus a liberal strategy, which is you start transfusing once the hemoglobin hits only 9, and then you keep it around 10. And you can see here that overall, this was all GI bleeders. There was a significant reduction. This is mortality. Okay, what I'm showing you here is overall survival was significantly better in the restrictive transfusion group. And in patients with cirrhosis, it was not significant, but when you looked at child class A or B, those benefited the most. That you had an improvement in survival in these patients with a restricted transfusion strategy. Now in child C, you did not damage them, so we recommend just restrictive transfusion strategy to everybody. Second, your general management is you do antibiotic prophylaxis. And why do we do that? Because in several 5 randomized controlled trials, these antibiotics were shown, and in these cases, they used non-selective, non-absorbable antibiotics. The theory is that with bleeding, there's an increase in bacterial translocation, so you wanted to decontaminate the gut. So these studies were mostly with norfloxacin, decreased infection, decreased death rate. And in many of these studies, many other studies, they showed that the rebleeding was decreased. So again, this was norfloxacin. Then a study came out comparing oral norfloxacin versus IV ceftriaxone in sick patients with cirrhosis. Granted, this was in a center that has a lot of quinolone resistance, and clearly ceftriaxone was superior to norfloxacin. We never had norfloxacin on the formulary, and now we don't even have norfloxacin at all. So clearly there are recommendations to do IV ceftriaxone. And then lastly, we use a vasoactive drug. We do not use propanol or beta blockers because this is more of a chronic treatment. And so, you want something immediate, an IV vasoconstrictor that will decrease splanchnic blood flow. And for this, we have 3 drugs: terlipressin, somatostatin, and octreotide. In the US, we only have octreotide. Thankfully, this study showed that they're exactly the same. This study by Tsao was criticized because they used low doses, but they used low doses for everything, including octreotide, where the recommended dose is 50 micrograms per hour, and they use only 25, but they also use lower doses of the other. So this is the dose that one should use, 50 micrograms at once in a bolus, and then 50 micrograms per hour. Then one does an endoscopy. Now, before doing the endoscopy, before knowing the source, it's totally reasonable to start a PPI. And but once variceal hemorrhage is confirmed, one should stop the PPI because PPIs have more deleterious effect than beneficial effects in a patient with cirrhosis. You do the endoscopy, you do a ligation, and one would continue the IV vasoactive drugs. Guidances say that you do it for 2 to 5 days. We usually tend to keep the patient for at least 4 days. If there's no further bleed, the patient is totally stable, one discontinues the IV drug and starts secondary prophylaxis. Now, if the patient rebleeds during this admission, that meaning they have failed standard of care, they have failed all these treatments, they go for rescue tips. Now, who are the patients that tend to need rescue tips? These are usually the sicker patients. Child C patients in many series have been shown to be the ones that usually fail the standard of care. And then they have a high mortality after you put a rescue tip. Why? Because they bled once, they bled twice, and now you put a tips in. So the issue is what happens if we place the tips preemptively in these high-risk patients before this failure occurs. So after you've done the ligation and everything is cool, but this is a high-risk patient, you're afraid they're gonna fail, you preemptively put tips in. And this is the preemptive tips or early tips. And I'm just gonna summarize this, and this is a meta-analysis that showed up like a month ago in gastro. And this is the high-risk groups chosen in most of these trials have been child C, 10 to 13 points, which makes sense. You're excluding 14 and 15 points because they're very sick patients. But they also have included child B that were actively bleeding at the time of endoscopy. This group has been a little bit more iffy. But you can see here that when they did this meta-analysis, and again, only 2 of them are randomized controlled trials. Well, this is the initial one by Garcia-Pagan, then there's a Chinese one, and the others are observational studies. But overall, they do show that this is survival again. There's a reduction in mortality with preemptive tips. When they, in this meta-analysis, because they had individual data, they could look at the different child categories, and clearly for child C, 10 to 13 points, this is again survival, much better with P-tips. When they looked at the B patients, clearly child B of 7 points with active bleeding, there was no benefit from preemptive tips. It was the Bs that had more than 7 points, that is 8 or 9 points, and were actively bleeding at the endoscopy. So the paradigm now is another shift. When the patient comes in, you calculate the child score, and decide whether if the patient is not or is a P-tips candidate. And if so, then you put the tips within 72 hours. That's early tips. And the candidates are child C, 10 to 13 points, and I feel a little bit more strongly about this group, or child B of 8 and 9 points that were actively bleeding at the time of endoscopy. It's important to recognize who are not P-tips candidates. These are child A, never put a tips in a child A patient, child B of 7 points, whether they are bleeding or not at endoscopy, and child C that are 2, 6, 14, and 15 points. In these cases, you do the normal. If they bleed, you are obligated to do rescue tips, because if not, the patient is going to die. If there's no bleed, then, which is the majority of the patients, you start secondary prophylaxis with non-selective beta blockers and ligation. So what is the evidence for the combination therapy? This is the evidence. If you don't do anything in a patient who has bled, the 60% are going to rebleed. This is the untreated group of many, many trials. Ligation and drugs have been the best to reduce this recurrent variceal hemorrhage. And all these trials, and look at them, there are a lot of trials, all combine cirrhosis versus no cirrhosis. They never stratify them by compensated or decompensated. So we wanted to know if this benefit applied to both compensated and decompensated patients with cirrhosis. So we asked for individual data, and we got this individual data meta-analysis, which I'm summarizing here. We looked at the trials that had the child A patients. It really made no difference whether they had been randomized to ligation or ligation and beta blockers. But it was the child BC patients, so sicker patients, that actually had a great benefit from getting beta blockers. The mortality, this again, survival was significantly better in patients that had combination therapy, and therefore the main element of combination therapy in, at least in child BC patients, is the beta blocker. Now, what do we do if a patient fails combination? Well, what happens when we compare TIPS? TIPS, after all, normalizes portal pressure and decompresses the varices. Clearly, rebleeding is much lower, 0 if you put a TIPS in. But why don't we choose TIPS as first-line therapy? Because it has encephalopathy and it could lead to liver insufficiency. So up to now, we still consider that TIPS is the recommended therapy in patients who experience recurrent bleeding despite combination therapy of non-selective beta blockers and ligation. We can then discuss in what cases we can consider this an exception. Now let's talk about ascites, which is the most common complication, and in the long term, it's a complication that carries the highest mortality. What is the pathophysiology? First of all, you have sinusoidal hypertension that forces fluid into the peritoneal cavity. As the patient gets sicker, but even in the compensated patient, there is some inflammation that leads to splenic and systemic vasodilation. This decrease in effective arterial blood volume and decrease in mean arterial pressure that activates neurohumoral system. And we've talked about this. This leads to sodium retention. This replenishes the volume, and that's why ascites is perpetuated. Now, if there's more inflammation as the patient gets sicker, they get more vasodilated, a further decrease in mean arterial pressure, further activation of these neurohumoral systems. So now the patient is retaining sodium so actively that they're no longer responding to diuretics. They now have refractory ascites. If now you get an excess of ADH, you will get water retention and you will get dilutional hypernatremia. And at the maximum vasoconstrictive effect, you get renal vasoconstriction that leads to a decreased renal blood flow and the hepatorenal syndrome. So like you see here, ascites, refractory ascites, hyponatremia, and hepatorenal syndrome represent a continuum of the pathophysiological events that lead to ascites to begin with. So they're all connected. So what do we do now for ascites? We give them sodium restriction and we give them diuretics way downstream of the pathogenic cascade. Not only that, but if you give them too much diuretics, you will decrease the effective arterial blood volume. You can activate these neurohumoral systems, leading to hyponatremia and to AKI. In this case, this is prerenal azotemia mostly. And in fact, prerenal azotemia from overdiuresis is the most common cause of acute kidney injury in patients with ascites. So what do you do with a patient with ascites? You have to recognize that diuretics are symptomatic therapy. It makes the patient feel better, but you're not improving their survival or anything else. You start the diuretics, therefore, once other complications like GI bleed, infection, acute kidney injury, encephalopathy are absent or have resolved, and go slowly. This is not pulmonary edema. You want them to lose 1 to 1.5 kilograms a week. There's no need to use IV diuretics. In a non-elective admission, and whenever a patient comes into the hospital, it's just the first thing I do, I call the diuretics. And in a patient admitted with ascites, the main goal is to make sure that they're not infected. So you need to do a tap to rule out spontaneous bacterial peritonitis. Now, what do we do with refractory ascites or with tense ascites where the patient is very uncomfortable? We put a needle in and take the fluid out, large volume paracentesis. This is way downstream, as far downstream as you can think of. And not only that, LVP has been shown to cause more splenic and systemic vasodilation. It will move the system, and this vasodilation is called post-paracentesis circulatory dysfunction that leads to further decrease in effective arterial blood volume, more activation of these neurohumoral systems, water retention, hyponatremia, and acute kidney injury, which in many cases could be hepatorenal syndrome. So in order to offset these deleterious effects, we give albumin, because albumin not only increases the blood volume, but may have vasoconstrictors that may cause vasoconstriction as well. So, and actually it also binds cytokines, so it may be an anti-inflammatory. So that's why we recommend albumin infusion, 6 to 8 grams per liter of ascites removed if you're going to do an LVP of more than 5 liters. But if the patient already has AKI, you should avoid large volume paracentesis or remove less than 3 liters and give some albumin, all right? Now, what about albumin, look at it, is acting upstream of the pathogenic cascade. Is albumin alone useful in the treatment of ascites and complications? So this is a very important trial. This is the ANSWER trial in the Lancet that randomized patients to weekly albumin infusions versus just standard of care. And they showed that the overall survival was significantly better with weekly albumin infusions. But not only that, they also these patients needed less large volume paracentesis, had less hyponatremia, spontaneous bacterial peritonitis, and hepatorenal syndrome. Problem with this study is that it was not placebo controlled, and therefore these patients with weekly albumin infusions were seen every week by their treaters, by their providers, whereas the standard therapy group were not seen that frequently. They were seen every 2-3 months. So clearly, if you see a patient every week, you're going to have better outcomes. So that's the problem, because in fact, there was another study that was much better designed that used a double placebo, that used albumin every 2 weeks plus midodrine every day, which was a vasoconstrictor. It made sense, and a double placebo, and they found absolutely no effect on survival and no differences either between treatment groups in need for LVP, renal failure, hyponatremia, bacterial infectious encephalopathy, or GI bleed. So one positive, one negative study. The mild in the ANSWER trial was 12. In the SOLAT trial, it was 17. So there were sicker patients. So it may mean that if you start this albumin in less sick patients, it may work. But again, we do not have enough evidence to recommend this. Now, let me talk about non-selective beta blockers in patients with ascites because of the bad rap that they have been getting. This is an individual meta-analysis in patients. All these patients had ascites. They had been in primary prophylactic or secondary prophylactic trials of variceal hemorrhage. So these patients with primary prophylaxis had varices that had never bled. And our outcomes, because these patients already had ascites, our outcomes were first bleed, refractory ascites, HRS, SBP, or hepatic encephalopathy, and was significantly lower in patients on beta blockers in whom the portal pressure went down, all right? And then we looked also at the secondary prophylaxis trials. These are patients that had bled already, and our main outcomes were variceal rebleeding, again, refractory ascites, HRS, SBP, and HE. And again, patients on beta blockers who were hemodynamic responders had a significantly lower rate of these bad outcomes. So beta blockers are good. I already showed you that beta blockers are essential in preventing rebleeding, but they can also be deleterious. If you think about it, propranolol decreased mean arterial pressure, and would activate these neurohumoral systems. But carvedilol is even worse because not only does it have this same effect, but it's also a vasodilator per se. So they will lead to further activation of neurohumoral systems, renal vasoconstriction, and acute kidney injury. So at least theoretically, this is true. This is a great study that was just published late last year in Journal of Hepatology that looked at systolic function, that's cardiac function, and renal perfusion pressure in patients with diuretic responsive ascites and refractory ascites before and after non-selective beta blockers. In the diuretic responsive patients, there was no effect of beta blockers on systolic function. And when they looked at the renal perfusion pressure, it went down significantly, but only one patient went under the threshold that perfuses the kidneys, the perfusion pressure that is required to perfuse the kidneys. Whereas in refractory ascites, they actually, the systolic function came down significantly. And importantly, renal perfusion pressure also decreased significantly, and 55%, 11 of 20 patients, had a decrease below that threshold that perfuses the kidneys. And in fact, 4 of them had hepatorenal syndrome. But think about it, there was the other half that had no, they reduced somewhat, but they never went under the threshold. But the bottom line is that in patients with refractory ascites, but not in those with diuretic responsive ascites, in patients with refractory ascites, one has to use non-selective beta blockers cautiously, and one has to maintain that mean arterial pressure over 65 or systolic blood pressure over 90. If the patient cannot tolerate that, even the minimal dose will lead to decreases in pressure. This patient cannot use beta blockers. Now, what is other thing that we can do to treat ascites that acts upstream of the pathogenic cascade is TIPS. TIPS reduces sinusoidal pressure and increases effective arterial blood flow. This is the way, but it's again, second line therapy. So what does it do? You have a bridge from the hypertensive portal vein, but also the sinusoids get decompressed through this stent. And actually all the blood that is sequestered in the splenic circulation now goes to the systemic circulation, so you're increasing the effective arterial blood volume. The problem and the reason it's second line therapy is because you have encephalopathy, which is authentically portal systemic encephalopathy, this portal to systemic. And you can also have liver insufficiency. And another complication that we have to be aware of is that with rapid reduction of ascites after TIPS, they can get umbilical hernia. We've seen several cases where there's intestinal ischemia from hernia incarceration. So in general, we recommend TIPS in patients in whom ascites is no longer responding to diuretics, but I think we've been waiting too long. There's now this study, this is the only study that used the stents that we're using now, which is Teflon cover stents. And look at this was survival. And these were patients that were randomized to TIPS. They're not a huge number, but TIPS had a better survival than large volume paracentesis plus albumin. Now, they were much more conservative in defining what is refractory ascites. So they just need at least 2 LVPs with a minimum interval of 3 weeks. We just had an ALTA consensus conference on TIPS where we're saying, you know, even if the patient is requiring a paracentesis every 2 to 3 months, one should probably be starting to think of TIPS. They exclude obviously patients, again, with that were very sick, bilirubin more than 6, creatinine greater than 2.5, or patients who had recurrent hepatic encephalopathy. Male, think about this, male was 12. So I think we are thinking of TIPS too late. What is interesting is that they found no differences in portal systemic encephalopathy between the groups. Now, this exact same group just published like a week ago in the Annals of Internal Medicine, this study of rifaximin administered 14 days prior to TIPS placement and its effect on overt portal systemic encephalopathy. And the results clearly show that the rifaximin group has significantly lower encephalopathy compared to the placebo group. Now, 81% of the patients had TIPS placed for difficult to treat ascites, which makes sense that you can start 14 days before. But I don't know how they did that in the patient with variceal hemorrhage. Maybe it was the patient who had recurred and then but they were now stable and they can start on the rifaximin. However, these again had the same MELD as the previous study that I just showed you. So I don't understand why in the previous study where they did not use rifaximin, they had no increase in encephalopathy, and here they're showing that is different. I think it lowers the rate of encephalopathy. So this is more to come about this study, whether we should be using rifaximin to prevent encephalopathy. Now let's go to acute kidney injury, which is the bane of our existence, especially in the hospitalized patient. This occurs in over 50% of hospitalized patients with cirrhosis, and is strongly associated with mortality both pre and post liver transplant. So our goal is not only to reverse it, but we want to prevent this progression. So what do we do when the patient gets admitted? We discontinue diuretics, beta blockers, lactulose, any potential nephrotoxic agent. We always work up for infection. If there's high suspicion, we start the antibiotics once the workup for infection has been completed. We work up for the type of AKI by getting a urine sediment, urine lyses, urine biomarkers of tubular injury, which hopefully we would have pretty soon, and investigate nephrotoxins. We replenish the intravascular volume. If the patient looks dry, just give them saline. If the patient is bleeding, blood. If the patient is neither dry nor bleeding, we expand the volume with albumin. If there's no response to these initial measures, we cannot identify anything treatable like an infection, we have to think, is this HRS? And again, as for refractory ascites, I think we have to start treatment sooner rather than later. And we have to use changes in creatinine, not absolute thresholds, to define AKI. When one uses thresholds, one could make a diagnosis of HRS in a patient who has a creatinine of 1 or even 1.5, all right? Now, because the main mechanism is vasodilation, we use vasoconstrictors. Now, think about this also. 15% of acute kidney injury and cirrhosis is HRS, only 15%. So you have to always rule out pre-renal azotemia and ATN before you deem that someone has HRS. And then you will use not only vasoconstrictors, but also albumin. So this is the combination therapy. And this is, I love this meta-analysis, this proof of concept where they correlated the change in MAP with changes in creatinine in the patients on terlipressin. And you can see here that if you increase the MAP by 10 millimeters of mercury, you get the maximum reduction in creatinine. So it makes sense. Now, what is the best vasoconstrictor? So it's vasopressin. The most potent is terlipressin. And we are now into our third North American trials to have the FDA approve this drug. And it was finally a successful trial. 29% HRS reversal with terlipressin versus 16% on placebo, statistically significant. We thought, this is it, we're gonna be okay. However, terlipressin resulted in more adverse events, including abdominal pain, most likely from ischemia, nausea, diarrhea, and respiratory failure, which was the worst because death within 90 days due to respiratory disorders occurred in 11% on terlipressin versus 2% in placebo. These patients were dying of pulmonary edema, and it makes sense, you know, you're increasing the post-load with terlipressin, and at the same time, they are given albumin. So you're increasing the preload. Then the problem is that the FDA required that HRS be defined as a creatinine more than 2.25. So these were very advanced HRS, and this is why I think they also had more complications. So based on this, the FDA just gave them a response letter. So we need more, they're going to require more data before this is approved for use. Now, let's talk about albumin and respiratory failure. I think increasingly we're using more and more albumin. This was a study that was presented in the European meeting last year, and it's about to be published. This was hospitalized patients, and they randomized patients to albumin targeted. So they gave them albumin every day or every other day, as long as the serum albumin was more than 3 versus standard care. And you can see here the primary outcome was new infection, renal dysfunction, or death. It was a composite outcome, not different at all, not different the composite nor the components of the composite. And on the other hand, they did have more serious adverse events, and these were respiratory failure compared to standard of care. So do not go crazy with the albumin because we can lead to respiratory failure. And not only that, there's a British study, it was much more expensive with the targeted albumin. So knowing that we currently don't have anything really, we don't have terlipressin, we have to be very mindful of preventing AKI. So we do it by preventing vasodilation by using albumin after LVP and with SBP, avoid vasodilators, careful use of non-selective beta blockers like I showed you. And what about preventing infection? Let me show you some data about this. This was the original study, again, very small numbers that showed that this is survival. Norfloxacin had a better survival than placebo. And when they looked at hepatorenal syndrome, lower hepatorenal syndrome with norfloxacin. So we're very happy about that. These are very sick patients. A more recent trial with a much larger number of patients showed no difference in survival between norfloxacin and placebo. This is in child C patients. And when they looked at kidney function, there were, again, no differences at all. Therefore, there's no clear indication for use of norfloxacin in the prevention of kidney dysfunction in cirrhosis. So now, what else do we have to do? We have to make sure we prevent volume depletion. You carefully use diuretics, like I said. You carefully use lactulose. The goal is not measured in cc's. It's measured in 2 to 3 soft bowel movements a day. We prevent variceal hemorrhage. And finally, we have to be mindful of the kidneys. So we have to avoid NSAIDs, avoid nephrotoxin, and cautiously use IV contrast. So in conclusion, what have I shown you? That in compensated cirrhosis, rather than screening for varices, we should be screening for CSPH. Portal pressure reducing strategies like non-selective beta blockers, and probably we will add statins in the future, can prevent decompensation. In patients with acute variceal hemorrhage, think of P-TIPS candidacy at the time of admission. Use non-selective beta blockers cautiously in patients with refractory ascites. Make sure that blood pressure is reasonable. In difficult to treat ascites, both serial albumin infusion and TIPS decrease the need for LVP and improve survival. We have to figure out which one we have to prioritize. Be cautious about excessive albumin use in hospitalized patients, and preventing AKI and its progression to HRS is important in patients with ascites. Thank you very much for your attention, and I can take questions now.
Thank you, Dr. Garcia-Tsao, for a very instructive, clear, and clinically useful grand rounds. We really appreciate it. This is an important topic, and it really reviewed everything very nicely. Perhaps, is there any role for non-selective beta blockers in prophylactic use prior to the development of cirrhosis in order to prevent it?
No, I don't think so, because by then those mechanisms, actually, we're not even, no. The answer to that is actually no, because even in mild portal hypertension, it's worthless. So that's why we're targeting clinically significant portal hypertension. In our Timolol trial, we were very naive back then. So when we did the Timolol trial, our goal was to prevent varices from forming, right? So that sort of comes to your question, not before cirrhosis, but these were very compensated patients. They did not have varices, and we had negative results. But in fact, we had included patients that had CSPH, and that the whole CSPH thing came from that Timolol study. And if they had mild portal hypertension, there was no effect from the beta blocker. They did not reduce the HVPG. It's only when you have clinically significant portal hypertension that the beta blocker actually reduce the pressure.
Great, thank you. Dr. Martin, I see you unmuted yourself.
Sure, Lupe, fantastic talk as usual. I'm glad that you endorse the use of statin agents in patients with underlying liver disease. As you well know, often the first thing that happens is when somebody's recognized to have chronic liver disease, the statins are stopped, and the mistaken impression that they're inherently hepatotoxic.
Right.
So would you like to comment on that?
I would love to comment on that. So right now, actually, we cannot recommend it openly in someone that doesn't have another indication other than portal hypertension and clinically significant portal hypertension. But if they have any excuse, you know, like if there's a little hypercholesterolemia, I would start the statins. Statins actually have shown in patients with NASH, statins have been shown to decrease, you know, aminotransferases. So they're not deleterious. You know, you have to follow them. They are not, like I said, there's an ongoing VA multi-center study to look at statins specifically to prevent decompensation. And the NIH they're just reviewing their studies right now to decide who are the centers that would participate in this statin trial to prevent decompensation. So we're very excited about that. Right now, I would say do not hold back. On the other hand, more so, try and see if the patient qualifies for statins.
Okay, thank you.
Now beware the decompensated patient, all right? Patients who are jaundiced and who are decompensated, they tend to have more rhabdomyolysis, not so much liver insufficiency, although there is a trial in Europe, there's a trial now in decompensated patients using statins, and the FEMA made them look at the safety, and they found much more rhabdo in the statin group, and some of them also came with an increase in INR, so there may have been some liver toxicity as well. So the decompensated patient, I don't feel that comfortable with.
Thank you.
Any other questions? I remind everyone to look on the chat for the link for the CME and the MOC credits, and I want to again thank Dr. Schiff, of course, for inviting such a special speaker, Dr. Garcia-Tsao, for all her contributions and today's excellent grand round. So thank you very much, everybody. Be safe, and we'll see you next week.
Thank you. Thank you, Jean. Stay safe, everybody.
Thank you.
Thank you. Thank you so much. That was terrific. And it's an honor to have you here. Thanks.
No, Jean, you've always been my supporter, even though I have unfortunately never worked directly with you. But I just feel like you're sort of my mentor as well. So, you know, you're one of my fathers of hepatology.
Well, I'm honored. But again, thank you so much.
You're so welcome, and I hope everything goes well. And you know, I ask the audience to feel free to email me or anything if there's any additional questions. All right.
Sure, and I want you to get over this injury that you had.
I mean, it's a drag, Gene. You know, what can I say? It's very difficult to do stuff, especially the rib thing that hurts so much. But anyhow, but other than that, you know, we'll survive, right? We just truck along.
We'll get in touch with you soon about anything you need. Okay.
Sure, that would be
Take
great.
care of everything else.
Okay.
Thanks again. Bye.
Bye. Thank you.